aggressively or treat passively. You want to certainly be more careful. 14-fold relative risk compared to people who don't have a family history. And even though if you go on to invasive cancer, it's not always invasive lobular cancer, it may be invasive ductal cancer. Again, showing it's a risk factor for genetics or for environment rather than a precursor necessarily.
Yeah.
So what's the risk factor for DCIS? The risk of developing invasive ductal cancer.
If you have DCIS, 10% of those patients will go on to develop invasive carcinoma on average.
But how do you translate that into 6-fold or for 14-fold? Is it equivalent to the risk of LCIS?
Yeah, I think it turns out about the same. Hope, is that how you describe it to your patients? That if somebody has DCIS, the risk of invasive cancer is, you know, how many
like
fold?
3%?
Well, it's
in the year or
complicated
something.
because if you have DCIS and you have a mastectomy, then your risk is less, right?
Right.
So you just have the contralateral breast that's left. So it depends on age, grade. You know, there's so many different aspects of it. If you have a little teeny low-grade DCIS, and you know, that's the problem. Is once you get into talking to a patient about their risk of developing an invasive cancer in terms of its implications, you know, should you have radiation, should you take chemoprevention, there are many individual details that play a role. So we certainly don't tell them they have a 14-fold risk.
Well, this is LCIS,
No.
and it's relative risk, not,
Right.
you know. So
Hyperplasia is 4 to 5.
4 or 5.
Yeah.
That's what I tell them, 4 to 5-fold. But you know that you have to compare and contrast that with people who have BRCA mutations and what their risk is lifelong, et cetera. But clearly, if you're young and you have a high-grade DCIS, your risk may be much higher than
Yeah,
that.
but I think if you take all DCIS and you look at 10 years or something, I think it's about 10% of those patients will go on to. But it's complicated, as you say, by the fact because DCIS we treat.
Yeah.
And
This is what I'm trying to
presumably
understand.
lessen the risk of recurrence. Because
Right, and then you know a lot of people in the past just had mastectomies when they had DCIS, which thankfully
whereas
they have.
LCIS, they may not.
They may
And
not
so
have anything. Actually.
people
Usually
are
nothing.
re-examining that, right?
Yeah, because they're so hard. I mean,
That's very
it's such a
controversial,
radical
right?
treatment.
No.
Yeah.
Right.
So we have a much better check on what happens to LCS because we treat the DCIS. You can't
It's
do
as
the
if you have,
experiment.
it's as if you had DCIS diagnosis and then didn't treat it, didn't do any excision, and that doesn't happen unless it was a misdiagnosis and you go back and that's where those
Or
numbers
if the
go.
But
patient
historically,
refuses.
why do you think that happened? I mean, you know, there's clearly an association with invasive cancer,
Yeah.
but maybe it's not quite as closely associated as DCIS. I mean, when you take out invasive cancers, you know, many of them are associated with DCIS, whereas LCIS is less common. So maybe a more malignant phenotype, DCIS, than LCIS, but also maybe it's just that people didn't identify it very well because they all look like lymphocytes
Right.
before we had special stains, so we don't have that.
Or the invasive lobulars, I mean.
Even the LCIS.
Yeah, I
The
mean,
LCS are frequently diagnosed as an incidental finding,
Right.
right?
and if you go back long enough in time, people were not so clearly in them. Pathology has become much more rigorous over time, and we're much more aware of what is a risk factor than we used to be. There's more data now than certainly when I trained. That is a while ago, but it's not.
The dark ages.
So I'll skip that and let you go on to invasive
Yeah.
cancer.
So there's invasive cancer. There's a wide spectrum of disease. Some people can have breast cancer that has been there for a long time, grown to a large size, and still has some metastasized. And other patients who present with metastatic disease, and you can barely find primary. So it's not all one disease. And there are different types that are reflected in the pattern that we see in the microscope, and we have names for those. But what's most important really is the grades of the tumor and also the stage. So the grade is what the tumor looks like, and that's what we look at in the microscope. The stage is how far has the tumor spread. How big is the tumor? Is it in lymph nodes? Has it gone beyond the reach of the stage next? So here's an example of a patient. This is a very rare view. When a pathologist sees this area, you have to take a picture because you may not see it for a very long time again. Because here you have an area of DCIS contained within the basement membrane, but here, there's a break in the membrane, and you have invasive disease right next to it. I have one more example of the same thing from my entire career. Here it is, and you can see how it's pouring in to the surrounding tissue and have invasive disease right there. The small cells out here are lymphocytes, but these are tumor cells. Now, what's much more common is the next picture, which is that you have evidence here of DCIS, and then out here next to it, there's a little island of tumor cells. So you know then that you have invasive disease, but you don't see the connection between the two because that section didn't happen exactly at that intersection. So we look very carefully at these little islands of tumor. And then that here is, you know, the careful pathologist, you know, you really have to examine the tissue very closely in order not to do this, because this is now invasive disease. It's outside the basement membrane.
Is there just two tumor cells there?
There is
No, there's
1, 2, 3, probably 4. So that's small. So we call that microinvasive. And if that's all you find, then it's less than 2 millimeters in size, and it's called a microinvasive focus of breast cancer. And that is, as far as prognosis, not much worse than just having DCIS. But if you see many of them, then it's probably a little worse. So it has to do with staging. Has become much more complicated than it used to be. So there are all kinds of gradation in staging too for how much and how big and so forth.
And Britt said, if you all see this, all these black spots, what are they?
Those are the
Lymphocytes, right?
lymphocytes.
And why are they there? Well, because the extracellular matrix is getting chewed up, releasing new antigens or something that they're being drawn, or you know, attractants that are drawn
So
them.
there are 3 more tumor cells, one there, one there, and one there. So grading of invasive lipocarcinoma next. So we do, grading happens, there are 3 different things we look for. Nuclear grade, 1 through 3. And clearly there's a continuum. So you have to then, as a pathologist, decide, does it fit in 1, does it fit in 2, or does it fit in 3? And so there's going to be some variability between people and between me looking at a case on Monday and on Thursday. If it's right on the border, I might call it one or the other. So there's some subjectivity to this. Gland formation, when a normal breast has globules and ducts, and they look like little glands. So the more differentiated the tumor is, the lower the grade is, the more of those structures you're typically going to see. You're going to see glandular structures. The tumor is trying to look more like the normal tissue, the more well differentiated it is. So we grade that from 1 to 3. And then we look for mitotic figures. A fast-growing tumor, typically higher grade, is going to have a faster growth rate, then we're going to see more mitotic figures. So we look for all 3 of those next. So this is an example of a very low-grade tumor. Almost all of these are small nests that are forming glands. The tumor cells are very, very small, basically no bigger than normal cells, and there are almost no mitotic figures. So this squarely goes into a low grade. So we would give it 1 for nuclear grade. We give it 1 because it has a lot of glandular features, and we give it 1 because there's almost no mitotic figures, so that would be a grade 3. I'm sorry, that would be graded at 3 points, and that's a grade 1 tumor. And next, yes,
Here's a question. How can you tell looking at those cells if they're a tumor and not the normal?
because there are no myoepithelial cells seen, and the pattern is totally disorganized. There are no lobules of normal shape or distribution. It is just disorganized, and like, you know, you could do a stain that picks up specifically myoepithelial cells, and sometimes we do that if we have, there's something called sclerosing adenosis that can look very much like cancer and look disorganized to some significant degree. And it can be tricky to tell one from the other, and then we can use that kind of stain.
And there's no basement membrane surrounding
No,
these things.
that's
There's some
hard to
special
say.
stains that also